It's more than an honor. It excites me. I love getting out of bed in the morning and going to work, and that's not always been the case. Injected it back into my hip. That was 9 years ago. I kite surf, I snowboard. I have zero problems. But
what do we provide that's going to be different? Or are we doing the same thing that everybody else is doing?
what a powerful statement. If we're still doing the same things we were doing 30 years ago, 15 years ago, we're probably not evolving.
How impactful is that word when we drop the F word, whether it's socially or...
That's a big part of escape spine surgery too, trying to make sure that we take care of the patient after we do the procedure. The reality is, we know you can do a perfect surgery, a perfect injection, but if a patient won't... Okay, so this is our second podcast, and I'm here with my two partners, Dr. Rafath Baig and Dr. Azmi Nasser, and we're here to talk about escape spine surgery and about our lives, and just to keep it authentic for the people who are watching this, so they get to know who you guys are. You guys have both done these procedures, and we're just excited to talk. Today's our second official day. So I'll start with you, Dr. Baig, my partner, Dr. Baig. Share with us a little bit about who you are, where you grew up, who inspired you. Somebody inspired you as a kid growing up to become a surgeon. Share us a little bit about your background, man. Tell everybody who Rafath Baig is.
Yeah, born and raised in Chicago. Who inspired me to be a surgeon? I will say it's people who told me I couldn't do it. That's who inspired me to do it.
Okay.
Moving on from that, becoming a spine surgeon was probably the same inspiration. It's something that evaded me during my training, and I had to go ahead and take on that challenge and not let it defeat me. And that's when the journey began. I chose to go ahead and get training in deformity, where you get to fix the complex problems and revision problems. And from there, my journey began to figure out better ways of doing what I was trained to do. I'm always of the belief, if I keep doing the same thing over and over again that I did 10, 15 years ago when I was in training, I haven't really advanced myself. I think if we continue to treat people like we did 30 years ago, what did we really accomplish or evolve into? We're still doing the same medicine. And that's why I think this partnership between yourself and Dr. Nasser was so precious to me. As a manipulation medicine expert that you are, you always wanted to go ahead and prevent patients from that same traditional F word called a fusion. As an interventional, I use that as a pun, but again, how impactful is that word when we drop the F word, whether it's socially or when we drop the fusion word in our practice? Everybody just kind of goes, scared. Oh, it's very scary. It doesn't take someone in medicine to understand how impactful that is, because it's all littered all over Google, Yahoo, whatever that may be, and how to avoid this. You're a subject matter expert with that. We go from a manipulative expert to someone who is an interventional spine provider as well. These conversations between you, Dr. Nasser, myself have been going on for a decade. Where do we go ahead and move on? What do we provide that's going to be different? Or are we doing the same thing that everybody else is doing? We're just simply,
repackaging it.
It's exactly it.
Yeah.
Are we just much more available to the patient, so they choose us to be on that journey, or are we providing something different?
Yeah.
And that is with these conversations over the course of the past 10 plus years. Here we are creating this fantastic program that I'm super excited to have.
Me too. Thank you. Yeah, what a powerful statement. If we're still doing the same things we were doing 30 years ago, 15 years ago, we're probably not evolving much.
We're not helping patients either.
Yeah. Azmi, you and I have been working together 15 years. So we started 15 years ago together. And what are you doing differently in your practice that's radically different than 15 years ago? I mean, how's interventional spine changed? Rafath's talking about, Dr. Baig's talking about surgical intervention, surgical improvements and innovations. What's new in your field?
Well, thankfully it has evolved, because back in the day, all we did was the bread and butters, like steroid injections, steroid. Epidural steroid injection, epidural facet joint injection, SI joint injection, all with steroids. We've been doing regenerative medicine with patients' own cells, like platelet-rich plasma, which is all I get. I haven't had a steroid injection in 20 years, and it's helped me stay, functional and active, and hit the gym, try to skateboard. I don't recommend skateboarding.
Skateboarding
I try to
doctor.
skateboard with my daughter. But so we can offer, different kind of treatments that might heal the body instead of just putting out the fire, making you feel good. So regenerative medicine has come a long way, but even the type of procedures we can offer for what is a bread and butter procedure, like the radiofrequency ablation. If someone has like arthritis in the low back and that's causing low back pain, instead of just quote unquote like burning the nerves, we can actually get in there, use the endoscope like Dr. Baig does, and find those pesky nerves and cut them and cauterize them. And instead of only giving like 11, 12 months relief, most people consider it semi-permanent. Like, we don't know if it lasts forever, but our patients that we did even like 7, 8 years ago, they still don't have joint pain. Like, you can still have other causes of pain in your low back, but I'm glad to see that even in interventional spine, there are other things that we can offer patients versus the bread and butters, the same old. And I mean, what's the definition of insanity? Trying the same thing over and over again. It's like, I don't know why these steroids aren't working anymore.
So an ablation versus a rhizotomy, just explain that to people that are listening.
Okay.
Just real quick, easy.
Real quick, instead of using needles and an x-ray to burn the nerve, where you don't even see, you're not looking at the nerve, you're just looking at an x-ray. And you're positioning the needle where you think that nerve should be. And you cauterize the nerve in a way that it will still heal. And that's why it only lasts about a year. Versus an endoscopic rhizotomy, through an incision that's skinnier than a dime, you can put a camera down, find where that nerve is supposed to be, cut it, cauterize both ends, make sure there's no other fibers crossing. And so that joint is not sending any more pain signals. And I would just want to like keep going and say, like, patients worry that they might hurt themselves if they can't feel the joint. But I tell them there's other structures, there's other body parts, like your discs and your nerves and muscles. If you try to lift a Buick and your body doesn't like it, it's still going to tell you. Just because you got rid of that pain, but
Yeah. And when you have an arthritic joint and you cauterize the nerve, the concept of you may not be able to the balance, the proprioception, that's what you're talking about. Patients are concerned about, I won't be able to feel it, so I'll injure the joint more, is what.
The joint or even something else.
The muscles,
like,
yeah.
They're not invincible now.
Yeah.
Like if you're trying, some of those exercises in the gym I see people do that I don't recommend, where you're really loading your discs, you can still herniate a disc. You can still hurt yourself. You can still pull a muscle, so.
Sure.
But it does provide amazing relief for our patients. They get to return to things that they used to not be able to do, especially that every morning I wake up and I can't stand up. It takes me like 10 minutes, an hour to warm up before I can really stand up. That's gone. And then, we just encourage them to strengthen your core, work on your posture so that you don't need more, you don't injure something else and then need something else done.
What about, I'm going to change gears on you guys for a second. So endoscopic, Dr. Baig, you've been doing a lot of endoscopic surgeries, and are you moving into, will you be moving cages into an endoscope? Is that something that you're starting to explore as an option? So for people that are listening, an endoscope being a tube, but you could potentially put a ship in a bottle and put an implant through that tube, right? And give a patient a fusion through a tube without having to have a big incision. Is that something you're you're starting to look at in your practice?
100%. It's
Okay.
not uncommon. As prior to us starting the podcast, I am at cadaver training centers, traveling nationally to learn this technique. It's no different than how we do it open. Now we just got to accommodate this through a tube, through various different expandable cages, percutaneous placement of pedicle screws. I don't think screws in the traditional fusion is going to go away when you have someone who's highly unstable and they've got excruciating back pain that's refractory to some of the techniques that Dr. Nasser talked about. Ultimately, the fusion is going to be the gold standard for
Sure.
them. But how do I provide that in a manner that is an outpatient procedure rather than multiple days in the hospital where we cut through the muscle, devitalize the muscle? If you get MRIs on these patients 6 months out of after, you can see nice beefy red muscle above and below the fusion, and at the level of fusion, completely devitalized. It looks like a high-grade Wagyu steak. I hate to put it in words of that, but it's more fatty and
It's not meat.
It's not
It's
meat.
not muscle.
It's not muscle. So having procedures available through us that dilate the muscle, right, temporarily, and allow placement of implants is going to be key to the future of spine surgery. We cannot be doing the savagery that we've been taught to do
Old school.
for the past 20, 30, 40 years. Everyone needs a blood transfusion. They're on their back for several days just because they can't get out. This is going to become an outpatient procedure where patients won't need to be wheeled out of the ambulatory surgery center. They're going to be able to get up and walk to their car.
Actually getting a fusion through a tiny tube and walking out a few hours later. That's
You know who
very cool.
did the first one in the state was us.
Very cool.
Yeah, through a tube.
Awesome.
Yeah.
So share with me more what you see from technological advances and you guys are going to the scientific meetings for endoscopic procedures, Dr. Baig. Anything new beyond that besides the expandable cages? That's obviously a big change. What about biologics? Are you seeing anything with biologics in spine surgery?
I would probably lean on Dr. Nasser for the
Okay.
biologics, but I will say they are. There's a lot of FDA trials in nucleus pulposus replacements. The nucleus pulposus is really the jelly substance within the disc, that little hockey puck that's full of that fun stuff that we herniate. There's actually replacements that are on the horizon right now, currently being studied at major university centers in Chicago and New York. So we're in human trials at this point in time.
Yeah.
So it's just a matter of time when that comes into play. We have facet replacement surgeries now, where we can actually just, as we would have to sacrifice the facets and fuse the patient, now we can go ahead and put in screws with viscoelastic attachments to it, so that it essentially acts as a disc replacement and does the same amount of bony removal as you would for a fusion if that was required. Wow. So lots of fun stuff on the horizon. Of course, some of the PRP, and then of course some of the stem cell stuff that Dr. Nasser does. Mm-hmm. But from the endoscopic standpoint, the instruments that we're using are being applied to more and more different areas of the spine. We do cervical now, we do thoracic now, as opposed to having to take down the rib to go ahead and chase a thoracic disc herniation. Now it becomes an outpatient surgery rather than waking up with a chest tube in you for several days.
Huge difference.
Huge difference, where anesthesiologists would have to deflate the lungs so you can get to that on one side. So as we develop these techniques and continue to go ahead and evolve our instrumentation, endoscopy is going to be the future. And we're super excited to kind of continue to evolve with that technology and apply that to our community here.
Sure. The tubes are getting smaller and the application's bigger, right? The indication's bigger.
Yeah, that's a good way to put it.
So Azmi, or Dr. Nasser, share with us about, you're using a lot of PRP inside the disc now, using platelet injections or PRP, regenerative medicine, to try to repair discs when you can. And share a little bit about that with us. What's your experiences with that?
There are other options besides just PRP for the discs. It's all about changing the ecology, the cellular, degeneration that's inside a disc. A lot of people say they have degenerative disc disease. I actually don't like that term. I don't think it's a disease. If you buy brand new tires and you peel out all the time and you got 30,000 miles on them, and they wear out, they're not
tires.
diseased. you just wore them out, So lumbar disc degeneration, I fully believe in. I suffer from it. I beat myself up. And there are certain ways, and like Dr. Baig said, there are studies now, and over the past 10 years, more and more studies have shown some efficacy of regenerating the nucleus pulposus. There's even allografts, meaning not from the person's body, that can help stimulate the growth of that nucleus, the center, like the jelly in the donut or hockey puck. And maybe that ends up being the future, but we're a ways from that. But we've been able to help a lot of patients with that kind of treatment. And I think it's going to be exciting to see where it goes from here. I know that for my spine injections, I've had PRP. You've had PRP and even bone marrow aspiration concentrate.
Yeah.
It's helped a lot of patients, but I think we have to be careful in which patients are appropriate for that.
Sure.
I've even had patients that had it done, and then I look at their MRI, and they're like 78. That's not going to reverse.
Yeah, the
78,000 miles.
The indications for that.
Yeah, for sure.
Yeah.
So we got to be prudent with that, and I think there's going to be a place for it, but I also think there's going to continue to be, just because humans do have wear and tear, we live on Earth with gravity, there's going to be indications for surgeries too, but it's exciting to see where the surgical applications are going.
Sure. So I have one personal experience with that, as you know, Azmi, with BMAC, with my hip. So I'll just briefly share. So 10 years ago, I tore my labrum on my hip, and you injected me with PRP. And I went back and looked at my medical records recently because I was going to be talking about this and I wanted to be factual. And the first time you injected my hip got so bad I couldn't walk. I'd walk 150 meters. I was like an old man, it was killing me. And you injected my hip with PRP, platelet-rich plasma. It lasted 10 months. Stopped my pain in my hip for 10 months. Then it came back with a vengeance. And the second time, you pulled my bone marrow out, my BMAC, bone marrow aspirate concentrate, injected it back into my hip. That was 9 years ago, 9 years ago.
Yeah,
I kite surf, I snowboard, I have zero problems. But I did my exercise with it.
That's true.
Yeah. These guys, the reality is, we know you can do a perfect surgery, a perfect injection, but if a patient won't change their lifestyle a bit, you're going to be limited, right? So that's a big part of escape spine surgery too, trying to make sure that we take care of the patient after we do the procedure. Making sure that we're really encouraging them for the long-term changes they've got to make lifestyle-wise to make sure that the procedures you guys do last long-term, right? That's a key aspect. Anything else you wanted to add? I'm just excited about being here. Anything you wanted to add before we finish our second podcast? We're going to do many of these. We want to be a source of information for our patients. So we'll be talking about different subjects that come up that you guys want to talk about, and try to make this a library for our patients for information. Is there anything you want to close with?
I think the only thing I would add is it's an honor and a privilege to work with you both. And I tell all my patients, hey, you know what? If this was my back, I would see Dr. Baig.
Yeah, I never dreamed I'd be working with, fellowship trained, board certified physicians like you guys when I started my career. And it's more than an honor. It excites me. I love getting out of bed in the morning and going to work. And that's not always been the case. But it's exciting with the trajectory of what we're doing. It's not easy. Everybody doesn't agree with us. We have our detractors. But I'll agree. I'm honored to work with you, Dr. Baig. I'm honored to work with you, Dr. Nasser. And we'll let you finish up, Rafath.
I will say the best part about this surgery was actually being able to understand the perspectives of, non-surgical providers, right? We're usually at tug of war of in this triad rather than working together. And because you come out of medical school and you go through your training and you want to be like your mentors who are very, very dogmatic and will not accept anything outside of dogma, right? Imagine what cardiology would be if the cardiovascular surgeons picked up on the stent, right? Where would GI be if we never understood what the cause of ulcers were? It was a bacteria.
Yeah.
There were very, very, very well-founded chairmen of surgical departments of very high universities that basically poo-pooed on that paper that says, hey, ulcers are caused by a simple bacteria. You don't need to do these big open surgeries, cut out the bowel and the stomach to repair this. And I owe it to you guys to go ahead and say, hey, what about this? And continue to kind of, chip away at that wall that I was trained to have, like Lord of the Rings, thou shalt not pass, right? You guys are laughing, but that's something that we hold so dear to us. And to continue to go ahead and say, well, Rafath, what about this? And what about that? And what about this? And keep that, cordial without having an agenda or anything else like that. And to kind of convince me just to kind of look at things from a different perspective. Hats off to both of you guys for allowing me to be sometimes being ornery and holding on to it, but also still accepting me when I decided to say, James, you're onto something. I appreciate it. I'm going to go out there and conquer this shit too.
Thank you.
Right on.
That's well said. Evolved. Very cool. Thanks, guys. Awesome.